Good afternoon, everyone. I'm going to let folks get mic'd up. Just go ahead. Okay. Well, I am really thrilled to be here to both kick off and facilitate this next panel on the state of Delaware. I'm going to start off by telling you why Nemours, a children's health system, decided to focus on population health, and then the model that we've been using in Delaware. And then we turn to our distinguished panel from the great state of Delaware. And you have each of their bios in your packet. And so I'll just briefly introduce folks. We'll go next with Helen Riley, who is the executive director of St. Michael's School in Wilmington, Delaware. And St. Michael's was recently visited by Secretary Arne Duncan, and he called it a model program. And Helen was one of the first people I met in Delaware, and really was in our first pilot on child care. And then we have Mary Beth French, who is a physical educator and chair of the Christiana School District PE and Health Content Committee, and has also done great work in schools. And Mary Kate Mauser will be the last speaker, who is Operational Vice President of Nemours Health and Prevention Services, an operating division devoted to prevention in the state of Delaware, and one for which I had the honor of creating over 10 years ago. But before I do that and turn it over, let me just go to the next slide and tell you about why Nemours, a clinical operation, decided to focus on prevention. We really decided that we wanted to go beyond our four walls and really get at the root causes of childhood illnesses and prevent children from having to go to our clinics and to our hospital. And so we expanded our approach from looking at biomedical to focusing on multifaceted view of health, from focusing on acute episodes to focusing on chronic disease and prevention, from focusing on individuals and patient panels to focusing on communities and populations. And there was a strategic decision to really focus on all the children in the state of Delaware. In our hospitals and clinics, we see about 50,000 Delaware children, and we decided to expand statewide to really improve health outcomes for 230,000 children in the state of Delaware. So today we're going to talk to you about our statewide approach. And finally, to focus rather than on disease, but to focus on health. And so what we were doing is really trying to integrate community and clinical into this integrated system where we're leveraging both the power in the community and also the clinical as well. And so this is the model that we're using in Delaware, and it really starts with a vision. And the vision is optimal health and well-being for all children in the state of Delaware. And we start with defining outcomes for a geographic region, in this case the state of Delaware. And our goal 10 years ago was to reduce the prevalence of child overweight and obesity for children between the ages of 2 and 17 years, to reduce that by 2015. And then using the best science available, we work on policies and practices that are science informed in multiple sectors, so in child care, in schools, primary care, and the community. And we made this another strategic decision that we would do all these things all at once in the state of Delaware. And so I think that's what we're going to be talking about today and what makes what we're doing a little different. And we're doing it in a way we've already talked about throughout today, which is really working with the community. In fact, the mission of NHPS is to work with others to help children grow up healthy. And to make the changes in policy in all these sectors and in these systems that care for children so that the healthy choice is the easy choice and that you get behavior change to occur. And I'll also say that the model was developed based on our work on obesity, but now we're applying it to asthma, emotional and behavioral health, and other areas as well. And we've really served as an integrator in the community, and by that I mean we work intentionally and systematically thinking about all the systems that care for children and thinking about the goals that we want to achieve and to improve outcomes. And in that sense, we work as an integrator that looks kind of like this. It's a little messy, But it really indicates all the different folks we work with. And there's not just one integrator, there's many integrators in the community. And one of the things we've learned throughout our work is to be flexible and to really take the lead from the community. So the last slide I was going to focus on, is just about spread and scale. We also made a strategic decision to both work locally and then to spread nationally. And so I'm going to go through this quickly, focusing on practice change, focusing on policy change. This is just an example of early care and education, where we started with trainings and the first pilot that Helen and her center were a part of. And then we worked at the state level on policy change. And we kept working. We worked with Sesame Street. We worked and developed collaboratives that bring together people to learn together about how to implement healthy eating and physical activity. And then we started working nationally. 5 years ago, we had our first conference where Bill and I brought together folks from both early care and education and public health around obesity prevention. And now we're working with the CDC on spreading the collaborative approach I mentioned earlier to 9 other states across the country. So it's one thing we've, I think, all alluded to in our discussions today is about spread and scale. And I think the time is right now for spreading and scaling what works. With that, I want to turn it over to Helen.
Good afternoon, everyone. So take a look at this little fellow. This little fellow and many more children like him spend 10.5 hours a day in my school. We have, well, let me tell you that what I'm going to do is tell you about a case study within our state case study. Because since we were the first pilot, we've been working on this for approximately 10 years. I'm very anecdotal with my presentation, but lest you think I'm talking off the cuff, I want you to know that we've spent the last 10 years in R&D, research and design, and that we've got the facts and figures to back up what we've been doing. So this little fellow and children all over the country like him have certain determinants of their health. Take a look at behavior, which represents 40% of a child's health, genetics, 30%, social and environmental, 20%, and quality health care, 10%. Since these children spend so many hours in early education, 10.5, 12 hours a day, most of their waking time, you can take the 40% of behavior and the 20% of social and environmental right there at it, and we have control over 60% of the determinants of children's health. Add to that that every child has to have a physical and immunizations, has to do that annually, gets a health screening every morning, and we at least can claim maybe 1% of the quality health care. Genetics, early childhood is all about early identification and then referral and intervention. So we address every aspect of a child's determinant of health. Okay, excuse me. Oops, there we go. So my messages begin early. It's never too soon. If you want to work on prevention, start when a child is born. Many of you have been parents, aunts and uncles, grandparents. You know that when a new baby is born, that is the time when adults are ripe for the picking to do everything right for that child. And that's what we do. We have 160 children from 2 months through 8 years of age. We also have 50 adults who work in the school and over 200 families that we interact with. So we have the potential to affect 400 people with everything that we do. Take a look at these pictures, and you will see children involved in activities around their health. But these are part of the activities that go on in the school anyway. The first picture shows children doing a dramatic activity. They did a play for their families. They reenacted Stregonona. And for those of you who know Stregonona, she is an Italian grandma who has a pasta pot that just keeps giving and giving and giving pasta. And that's what we did that evening. So the children have their pasta all over. The second picture is a particular favorite of mine because it's an outgrowth of a project we did with NHPS where children planted gardens. So the older children had plots and individual gardens, but even the youngest babies, this little girl is 1 year old, the families were asked to bring a pot, and the children planted lettuce gardens in the pots. So the beauty to me is this little girl's mom brought in a big tub of sugar cookie mix, and she took it back home with lettuce planted. Early childhood programs are a good place to start because we're good partners. We are very closely connected to the communities. Our parents come into the building twice a day to drop their children off, pick their children up, and we have a high level of trust and a strong relationship that's built with them. So one of the things we want to do is teach children healthy living and use that, then pass it on to the families. With children, we have to keep lessons clear, short, and simple. State lessons positively because although children all can say no, children don't really understand the concept of a negative until they're over 3 years old. So state things positively and repeat them often. Integrate the information and good practices across the curriculum. That means in STEM, in language arts, and also in the arts. And keep it real. Children learn best from hands-on activities. So here you see a little girl working on a project with carrots that they've grown at the school. And the other thing is be a good role model. And that I can't stress enough because that's the strongest form of teaching. The other photo shows a new playground that we put in that not only has a lot of areas for the typical climb and slide or swinging, but it also has areas it has running paths, it has places to take a walk, places to lie down in the grass and roll around, so kids are learning to use their bodies. Exercise. Try activities like movement to music, yoga, and dance. Activities for children need to be balanced between structured exercise, organized games, and free play. Everybody doesn't have to get up between activities and do jumping jacks. And families don't have to practice to run a marathon. But children by the age of 4 can start to develop their own health routines, and they can teach their children to play with them so that the whole family is playing. Let's look at the net. Oh, and do you see in those slides a 3-year-old who is moving through part of an obstacle course that was set up. And in the other photo, you see our 2-year-olds playing basketball with Secretary Duncan. On the next slide, you can see nutrition, and these are lessons children can learn. And listen to how concise and simple and positively stated they are. Eat fresh fruits and vegetables. Whole grains are best. Drink plenty of water, learn to cook, and try something new. So these children were making pasta salad, and then they cleaned their plates. Now, the next slide shows something that we haven't talked about at all today. I haven't heard anyone talk about rest and relaxation. And I happen to think that's an extremely important part of well-being, whether we're talking about obesity or anything else. There's a lot of anxiety in our culture. There's a lot of stress, a lot of being really overly tired and worn out, particularly among young children. And so quiet time is important. We need to get enough sleep to restore our bodies. We need to learn to manage ourselves so that we feel in control and make a plan to enjoy your life. Now here comes the warning. It's in sustainability, because we've been really successful with all the things I've told you about, and our children are fantastic. But what we've decided we have to do next is the children become the Trojan horses. They carry the message we've taught to them to their homes. Look at me. I haven't really practiced what I've been preaching. I've been so focused on what we're doing with the children that the teachers and I and the parents and I have not concentrated on presenting ourselves as the best models. So about 6 months ago, that's where we changed the focus to incorporate family involvement much more. If we're going to I think we know how to do prevention in early childhood. If we're going to talk about sustainability, then we've got to involve all of the adults who come in contact with the children at the schools and in their homes. Thanks very much.
I'm very excited to be here and presenting in front of you to tell our story. Concern for childhood obesity got the attention of our Delaware legislators, and General Assembly passed legislation in 2006 to pilot physical education, physical activity programs with the goal of students to be moderately to vigorously physically active for a minimum of 150 minutes per week. Policy changes included interested parties in the policy development and implementation, but what grabbed educators' attention was the alignment to the things that educators are accountable for, like academic success, attendance, behaviors, attention to task, and executive function. All right, Helen, what's it? There we go. These are the key factors in the successful development of the piloted programs. Each school formed wellness committees and then attended trainings held by Nemours Health and Prevention Services, but also with the Delaware Department of Education. All of these components listed helped launch the pilot programs not only in the original group of schools, but also help with scale and spread to other schools in the state of Delaware. These are the programs that continue today, 8 years later, in many of our Delaware schools. Featured here is a ride and read program that started in our school where students can pedal stationary bikes while reading. These bikes are located throughout our building. They're in classrooms, they're in pods, and they're in our library. Other schools have also adopted this type of a program in their schools. How did we overcome the barrier of finding time in our very tight schedules? We made it easy, we planned ahead, and we embedded physical activity during the school day, like our morning exercises and our regular routines, and also in the subject areas using programs like Take 10 and North Carolina Energizers. We have a review process in place where we take a look at data and student surveys, and it helps us answer the question, how are we doing? And from there, we make adjustments to our programs. We took the approach of it takes a village and created a matrix of leaders rather than a hub. And this way, as new ideas and programs are created, so are the number of leaders. To renew our energies, we must have opportunities to attend collaboratives and conferences with partners and with potential partners. We have to celebrate our successes because it is a key factor in giving us a chance to take a look at our progress. Here is the results of our work with the Alliance for a Healthier Generation and Nemours Health and Prevention Services. This is one of my favorite pictures of our, and I affectionately call them our lunch ladies. This was a group of people that were not involved in our school. They came in the back door and they left in the back door. No one really knew them, but because of our comprehensive program, they've been included and are a vital part of serving our vegetable harvest from our school gardens. Obtaining financial backing is also essential to maintaining and improving our programs. To accelerate our movement forward, we need to take a look at continued collaboration, as mentioned, but also professional development for all parties. If we're going to change the culture of our schools to embrace physical activity as part of our daily routine, we need to take a look at the bigger picture. We need to make changes at the national level. For instance, our pre-service teacher education programs need to make physical activity breaks part of their lesson development and make it an expectation and not an addition. These are methodologies and best practices for students' learning. And by doing this, we will increase our students' healthy behaviors and successes. Thank you.
So thanks for having me here today. It's great to be on the panel and hear about the great work that's going on. And really what you see here is a conceptual model of the work that Debbie talked about at the beginning of the presentation. And this is what happens in Delaware. And you've heard great work from two of our partners. And what we really do at Nemours is we try to help our partners be as successful as they can. We try to remove barriers, we work with them, and we really take the lead from them as what we should be doing and what we shouldn't be doing. One of the things that we talk a lot about, though, is about evidence. Is our work making a difference? Are we doing the right types of things? Are there other things that we need to be doing? And so we talk about it from a word of impact. We all use that word day in and day out in our work. So what is the impact? We are seeing impact in the work that we're doing in Delaware. It's both quantitatively and it's qualitatively. But what we know is there's much more to do. We heard that in the first presenter today, and Kaiser Permanente's work that they're doing is amazing. And we have to continue to share what is working and what is not around evaluation. What we can say here in Delaware that we know that there's evidence is that in schools we can show that a child who is more physically fit is able to have greater academic achievement. We also can say that in the work that we've done in child care centers, like you heard today, 100% of the child care centers that participated in pilot work with us showed an increase, 100% in active living and in healthy eating in their centers. We also know that the number of children that are being screened early and appropriately is increasing. And we know that children in the Y catch sites who we worked with across the state who are participating have increased their physical activity by 20%. Policy change also is a part of the work we do. And there's been many policies that we've tracked that we look at to determine our impact that we're having. Child care regulations for healthy eating and active living, fitnessgram and physical activity legislation, reimbursement for the work that we're doing, $30 million of funding for the built environment, over 500 miles laid down for public trails and multi-use pathways, and an investment of $23 million in early childhood systems. That's how we're looking at impact, but we also want to take a look at it at the population level. Whoops. There we go. And one of the ways that we do that is really to look at a Delaware survey of children's health that we launched in 2006. And we actually are on our 4th iteration. We did it in 2006, 2008, 2011, and it's in the field now. And it really has shown that it's helping to fill a significant gap in data that's needed in Delaware so that we can make informed decisions and make the work that we're doing match up with really what the priorities and the needs are. At a population level, we can see from this survey that the rates of overweight and obesity among Delaware's children have leveled off since the survey was first administered in 2006. This finding was also supported by additional behavior change findings related to fruit and vegetable consumption and sugar beverage consumption. Unfortunately, we do still see that screen time continues to be a threat to children's health. One of our barriers has been ensuring that we've identified the very best indicators for which we can efficiently and effectively collect data to track the outcomes that we are seeking to measure. This becomes challenging when we must secure data from our community partners who are voluntarily participating in initiatives with us, and we are trying to demonstrate the collective impact of our joint efforts. As you can hear from our partners here today, we all have many things on our plate. We must make sure to mine and analyze the data collected and present it in a format that is actionable for us and for our partners. It's got to be a two-way street. Health equity and disparities work is really a new adventure for us at Nemours. Over the last 2 years in our work, we've really started talking about having a lens of access and equity in all of the work that we're doing. We feel like it is very critical for our future work that we focus intentionally our efforts to diverse populations with the most appropriate interventions that are supported by best evidence to reach a tipping point in addressing health equity and improving child health outcomes. We must mine and interpret the data collected in our evaluation and needs assessment efforts to ensure that we are reaching the populations and the geographic areas that need the most help in improving child health outcomes, and that we are considering their needs culturally and the environmental factors that influence their ability to achieve those outcomes in selecting the evidence-based or promising practices to introduce. Also, when we think about sustainability, there's really 3 things that we feel like are very important in our work to make sure that we do. We must be opportunistic in determining which policy, systems, and environmental changes to drive and at which time that they will be sustainable and lead to improved child health outcomes over time. We hear that word time again. We must identify and mobilize grants and maximize other funding streams with partners and coalitions to generate the resources needed. That's really about blending and braiding our resources that are available. And we also must build the programmatic and leadership capacity with targeted community partners and coalitions to really be able to spread, scale, and sustain policy systems and environmental changes over time based on shared goals, making sure that we're all there together with the same goals. And so the bottom line, or the silver bullet to putting in place a sustainable statewide strategy to combat childhood obesity, is to have effective leadership across sectors at all levels who are willing to make an investment needed to make sure that policy, systems, and environmental changes that help children to grow up healthy and have improved health outcomes is really there. It's a necessary, and we are doing it in Delaware, as you can hear today. So I'll leave you with a Helen Keller quote that I really think sums up the conversation that we're having today. Alone we can do so little, but together we can do so much. Debbie?
Can you hear me? Great. We have 20 minutes to field questions. I'll start with a few, but I want people to be thinking of your questions and come up to the mic. We'll also have questions from from our web audience as well. So sticking on this theme of leadership, what specifically do leaders need to think about if they want to replicate something like this? And we've talked about leadership being the secret sauce. You know, is leadership always at the top? So those are some of the questions. Mary Beth, I think you got...
It may have, actually in this case, it did start with policy change. And in my district, it did not necessarily start at the top. In 2006, I presented as part of our district wellness committee the benefits of physical activity, educated them about the trends of the childhood obesity, and then went through the list of benefits, not just with the student themselves, because some were looking at, well, what's it in for me sometimes, looking at the future of our health system, and then, of course, talking about the academic benefits and how it will better the schools. And from there, we brought on, we started with a goal of 6 schools. We ended up with 12, signing on with an MOU to say, yes, we're in. We want these resources in our building. Come train our teachers, come train our staff. We use the CATCH program, which is a coordinated approach to children's health. And in there, forming our wellness committees, we need to have a diverse group. And there's a thought behind it, is that no one person, you may start off with one school champion, but every person is bringing their perspective to the role that they play in the school and what they can do. And from there, we actually have expanded. Many classroom teachers have stepped up to take on after-school programs, before-school programs. Our vegetable garden is probably one of the best in the state. Of course, I have to brag about that, because we are teaching the education of the sciences, but also the healthy eating. I've never been in a school where kids are actually excited about eating radishes. And this isn't something that I said to everybody saying, please bring somebody, take on this role, take on that role. They just start to come. So as you develop it, they will come, like our field of dreams.
Others?
I think I'd like to continue to address the issue that I brought up about myself and about not practicing what I was preaching. So as a leader, I've been extremely successful in getting a program in place that's benefited our children. What I did not do was understand the impact that that program could have, that the circle could be much wider by incorporating all of my workforce, which is over 50 people, and then all of the families of those 160 children. So just in the last 6 or 7 months, as we've expanded the focus, you should see the difference that it's made. The parents want to have yoga classes along with their children. They want dance classes. They want recipes. So we're starting to provide all of those things. We had all summer Dad's Night on the playground, where dads come in and they don't kibitz while the children climb the slide and go down. They are actually doing activities led by our physical education teacher. So I think that we have to understand that with early childhood, we have an opportunity to address a very large population. And when the school is successful and the parents love it, they go home and they talk. They talk to their friends, their neighbors, their families, and now, you really could expand 2 and 3 times the size, which tells me people want it. So it's got to be expanded to other programs.
We talked about this morning. It's really about having the dream and the vision. Leaders come in all shapes and sizes, and as I said, it's leaders at all levels of the organization coming together. And so leadership does have to be there, but it comes in different forms, in different places, and in different ways, depending on what you're doing.
Thank you. I see there's a question over there. Then I have some others as well.
Hi, I'm Helen Matheny. I'm chair of the West Virginia Healthy Lifestyle Coalition. I want to thank you all for presenting your case study today. It's very informative. Just a couple quick questions. Do you have a leadership council of representatives across the sectors, and what type of governance is there for this effort? And then also in terms of funding, what is the funding source and amount? And you talked a lot about sustainability. I appreciate that.
So this is an initiative, a statewide initiative that was really got off the ground with support from Nemours. But Nemours at the very beginning under Debbie's leadership really said, we're not doing this alone. We have to have our community partners side by side with us in figuring out how to do this. And it's really been led by partners. There's not a coalition that oversees this work. There are coalitions that are a part of this work that have come out where we bring partners together. We have 3 coalitions in each part of our state, as well as networks that have been set up, mostly made up of either nonprofits or residents. But the driving force really are women and men and families, like you're hearing today, that are saying, we want to be better tomorrow than we are today. And so it's really taking the community, the needs, and looking and seeing what those are and driving forward from there. So it's a very organic approach in some ways. But you saw the model that Debbie presented as well as the framework. So there's a tool belt we're wearing, and we're trying to figure out what tools are needed for which situation, which environment, which community, which partners that we're working with.
The only thing I would add is that part of the strategy, too, was working in partnership with community partners, because when we found shared goals, mutual goals, then they also brought their resources to the table. And so if you looked at the in-kind resources that both Nemours and the community folks brought to the table, and not just in-kind but other resources, you know, you have to count the whole picture is what I'm trying to say, but part of the strategy on sustainability was helping to build community capacity. Question here? Oh, can you say your name and organization? Oh, go ahead. I'm sorry, Lynn, I didn't see you.
Oh, I was just going to give a question from the web audience. How does Delaware and the school district measure changes in health behaviors? Self-report by students in surveys, biometrics?
Well, we do use the FitnessGram, fitness testing. We've been using that, actually piloted it before it really went national. We use those fitness results. The state of Delaware we have a House bill where 4th grade, 7th grade, 9th and 10th graders must report their fitness results to the state. So we're testing anyway. Typically, schools are testing 3rd through 12th. We are in the stage where the program allows us to print reports so that we, at an individual school level, can take a look at results and see how are we doing. And I've used that to help tweak some of the programs in our school. For instance, we noticed that muscle strength is not, especially abdominal strength, was not scoring. We didn't have as many students in the healthy fitness zone. So we invented the rock and read, since we already had the ride and read with the bikes. So now we have theraballs where the students can sit and they can rock and read. Some of them use it in their classrooms just as a chair rather than having them sit still and try to fight the wiggles. We've joined the fun. So we do use we also use some student interest surveys in our school to find out what are the students liking, whether it's the morning exercise, recesses are right, so they're enjoying what do they like at recess, because just because they're going outside doesn't mean that they're physically active. So we try to find out what their interests are, so we're maintaining those basketball hoops because that is definitely an interest. So we are using data more at an individual level, but definitely at the state level. I know Nemours is using that.
Yeah, just as Kaiser talked about intermediate outcomes and population health level, as Mary Kate talked about, we also field this population health survey. And that is a representative sample of children in the state. It's parent reported, but it's been crosswalked and validated with the medical records, of course, with informed consent and all of that. So it's parent reported, so you can look at by age, you know, what the behavior change has been. I see we have a lot of questions over here on the right.
I'll be brief. Erin White, I'm an associate director with FSG. We're a nonprofit strategy and evaluation consultancy and also do work to try and build the field of knowledge around collective impact. I'm supporting work in Dallas right now and have been for the past couple of years. The Children's Medical Center here, it's a 100-year-old nonprofit children's hospital, has recently started some population health work. One of the big struggles that we've had is there isn't a community health survey in Dallas. They do use FitnessGram, somewhat unsurprising, but they don't have sort of a strong public health department who can run it, and each of the hospitals and the competing health systems is collecting their own community needs data. So making the population level case for this is challenging, to say the least. So I'm wondering how you were able to get that kind of comprehensive statewide measurement. Did you involve other health systems? Was it partnership with the state? Quite practically, how could that sort of assessment be brought into communities like Dallas that don't have it right now?
You want to talk about the early years?
Yeah, and it was, we had, just like Dallas, we had a need. And we knew we wanted to measure population health level outcomes because we were doing, because we wanted to look at the impact of our efforts. And so it was part Nemours. And then we also had the advantage of the Robert Wood Johnson Foundation. They also enhanced our ability to do this. And so it was a combination of those two things. And over the years, we've been able to bring down, the cost of being able to do that. And we can share, we'd be happy to share that with you.
One of the things I think you bring up a really important point is that it's really important for us to have different times to come together. Peter's coming to Delaware, and so we're forming a close bond because of the work they're doing and the work that we've done.
Great, thank you. Over here.
Hi, my name is Joseph Bivens. I'm the author of Chunky and Friends, Chunky and the Obese. It's a book I created to jumpstart the conversation with kids about healthy eating, active play, and some kids' childhood obesity. The question that I have for you guys is, in terms of engaging parents, I know you have the Trojan horse strategy, but in terms of engaging parents to get them involved in the process and in their children's lives directly, how are you doing that? Do you have any plans on doing that, or is it just going to continue on getting to the children first?
Well, I'll address that. I think that a couple of the strategies that I mentioned in my remarks. One is to start as early as possible. So if children can come to us at 2 months, we get that family right at 2 months, and we start to talk about them. We were very successful in building a community of people around valuing education. So now what we're doing is we've got that in place. Now we're extending our community to value health. And so we talk about it all the time. There are messages that go back and forth to the homes. We ask questions. I sit in the lobby of my school every day from 4:30 till 5:30, and I engage parents in conversation. So when we talk about establishing relationships, that's it. And when children are leaving and I stop and say, can you tell your mom what vegetable you had for lunch today? Or can you tell your dad what was on the menu this morning for breakfast? And did you like it? And do you want it again? And when I ask children those questions, the parent is standing right there and they're hearing the child say, I love beets. And the parents sometimes go, ew, beets. But mommy, they're good. All right, let the child make the case.
Yeah, I think I'm asking because whenever I'm out selling the book and I speak to physician friends of mine, I notice that when I'm introducing it, the child is really into it, and the children are very receptive to healthy eating.
Right.
But then the parent will turn and say, point to them if they're overweight or whatever health issues, like, yeah, you are. It's a lot of finger pointing. So I'm just wondering if you guys experience that as well, and how do you deal with that whenever that comes across?
At our district, if it's okay, at our district level, we have a policy new this year that healthy celebrations for whatever, so parents that are coming in, we're not the cupcake police, but we do approach with the food allergies, that it does have to be something that is bought, but it does need to be something that's healthy. And we're finding that the children are very, very receptive to having a healthy snack as their celebration because it's something different, whether it's fruit. In one of our schools, it actually became kind of a challenge for the parents at how can we make the fruit look like little animals or decorative. So they had fun with their food, if you will. The other thing that we've done at our school, and again, just started last year, since we've had a very successful vegetable garden, we've brought parents in at night, and we partnered with some community members where they donated seeds so that they would start developing and planting their own vegetable gardens at home. So we're just starting to branch out, and that is something that we're trying to figure out, how can this be successful, and take what we're doing already in school, because we do let them know. We take the approach, here's what we're doing at our school to make sure that your child is healthy, and then we're giving them the opportunities to expand that to their home.
One of the things, we are really starting to look at how we can do multi-generational approaches to the work, and really being strategic and thinking about how we involve families and children from the get-go in all of the work. Some of that is early on, is working with our partners to do similar things like Mary Beth talked about related to community dinners. We've had a lot of success in that throughout the state. Working with partners on doing gardening together. Mom and dad, grandmother, child are together on doing gardening. So lots of different things like that. Also, on recent work that we're doing, we also have advisory councils in our physician offices. And those advisory councils that the physician offices are leading are really informing the work, and the parents and families are really a part of what we need to be doing. And they have ownership, and I think that's critical as we move forward and do more work in this area. It's definitely needed.
Our time is about up. I have one last question for the panel, so then those of you who are standing after these folks will be around and they'll be happy to answer your questions. The last question is, this is a statewide focus, this panel. So my question to everyone is, given that it's a statewide approach, what are the advantages and disadvantages of having a statewide approach that's so comprehensive? So, I can begin by saying that, in the very beginning, when we decided to work in all these sectors all at once, it was a lot to do at once. And now looking back, it's paid off to approach it that way, but at the time, it's just a tremendous amount of work. I guess the other thing is the measurement at the statewide level, getting the population health measurement is really important, but we get the question all the time. Was it the child care strategy that was most important, or is it the school strategy that's most important, or the primary care strategy? And we can't answer that question. We know that it was all, Mary Kate talked about the results, it all made a difference, but we can't look at it like in that level of detail because it was a statewide approach with a lot of things happening at the same time. But Mary Kate, you might want to also add to that.
Well, and I think it's really about the model. It's how all of those things came together, and it's about not how they were each siloed, but how we have smooth transitions between each of the sectors. I think that's really important and still a work in progress. But it's, it does take everything. And you do have to prioritize, and part of it is depending on the readiness of the community. It's also, in a state of Delaware, although it's a small state, it is very different. If you're in Sussex County, it's a very rural population. If you're in inner city Wilmington, it's a very inner city population. And so it's not a one size fits all. And so the approaches have to be customized appropriate, taking into the great diversity and cultures that we're working with in our state.
And I think statewide is a benefit because now it's an expectation. And just like you mentioned, it doesn't mean, though, that everything's going to look the same in every building, and that's where we have that flexibility to develop our own programs.
Final word, Helen?
I do think that the early childhood sector is, excuse me, more important than we've realized. I'm one site, but being able to see how successful we can be and knowing that there are other programs, what we need to do is coordinate early education and elementary education. Now, my program goes through second grade, but that transition should be smooth, and what we're doing needs to coordinate with what they're doing. Of course, that's no different than what we're talking about, reading programs and everything else about children growing up and moving through school systems. The other thing is, education has not for those really good things that they've experienced and to push for them in the schools children go on to. So it may take 10 or 15 years to reap that benefit, but knowing we've sowed the seeds and that we're continuing it, I think we will.
Well, I really want to thank our panelists. And I get the pleasure of introducing the next panelists. And our facilitator for that will be Brian Smedley, who I see he's coming up right now. Brian is also a Roundtable member. He's got a distinguished bio in the packet of materials. He is the co-founder and executive director of the National Collaborative for Health Equity, and he'll facilitate the next case study presentation and discussion. It's called Place Matters, a County Example.